Good evening, everyone, and thank you for joining us this evening for our open session for the collapsing dog, is it cardiac? So before we start, I just want to let everyone know that this session is being recorded. My name is Beth Dunn, and I'm the Programme Coordinator for the Advanced Certificate in Small Animal Cardiology at Improve. And with me tonight, I have Stephanie Godfrey, Operational Head of the UK, US and Nordics, and Lara Barron, a European and MRCVS recognised specialist in veterinary cardiology. So this evening, we're going to start with an overview of improved veterinary education and our advanced certificate in small animal cardiology starting in July 2023. We will then turn our attention to the talk of the evening. Lara Barron, the course director and one of the lecturers on the advanced certificate in small animal cardiology, will share her knowledge on the collapsing dog, is it cardiac? So we'll be taking questions via the chat box, and at the end of the session, there'll be an opportunity for you to ask us questions about the Advanced Certificate Programme and to ask Lara questions about her presentation. You can use the menu shown on the horizontal bar below to send your questions to us. So to start, Stephanie is going to give you a brief overview of Improve International.
Thank you, Beth. Good evening, everyone, and welcome to tonight's session. Thank you so much for joining us. We thought it'd be really helpful to give you an introduction to Improve Veterinary Education for those of you that may not be familiar with the Improve International brand, before going on to talk a little bit more about the Advanced Certificate in Cardiology. So Improve Veterinary Education has been providing CPD to the veterinary profession globally for well over 20 years and was the original moderator of Modular CPD. We are continually adapting and innovating our teaching and learning styles, from face-to-face lectures and practical components to the more recent online and blended learning programs. We're truly global, offering CPD in over 20 countries such as Japan, America, the UK, Australia, and most of the European countries. In 2020, we delivered over 400 different CPD courses, providing around 1,000 days of training to the profession. The Improve International brand was created by a group of vets passionate about delivering high quality continuous education, and this is still the case today. By studying with us, you will take back to practice new skills, knowledge, enthusiasm, and confidence to handle those challenging clinical scenarios. Throughout the programme, you can start towards a recognised qualification. For the Advanced Certificate in Cardiology, this is our General Practitioner Advanced Certificate, which is provided with the accreditation with MRCVS and validated by Harper Adams University. For some delegates, there will be the opportunity to proceed on to a postgraduate diploma in veterinary science with Harper Adams. So why our advanced courses? We now offer a suite of advanced certificates in a variety of programs. The newest ones are Advanced Cardiology, and this will be joining us in June 2023. The benefits of the advanced certificates is really building upon our GP Cert and PGC programs, but the benefits will return to practice, will increase your skills and confidence, reduce your referrals, and increase your own personal skills and transferable skills to others in your team. The Advanced Cardiology Certificate will commence on the 21st of June 2023. It's a 14 modular program delivered over approximately 4 months. Within the 14 modules, 2 of these have practical components, and these are 2 on advanced echocardiography. We have veterinary specialists to support you through each of the 14 modules, and Beth is a dedicated program coordinator. The program has been built on our build on from our general practitioner certificate in cardiology. However, delegates don't have to do that program first, as long as they have suitable knowledge in cardiology and have been in practice for a minimum of 5 years, then delegates can take the program without taking our GP Cert cardiology program. However, if preferred, there is the GP Cert program that does start online in May 2023. Okay, so now we're going to move over to tonight's session of the collapsing dog, is it cardiac? I'll be passing you over to Lara Barron, who will be able to introduce the topic and walk through for the next 45 minutes. If you do have any questions during the session, you can use the chat box below the screen, and we'll be taking questions at the end. We hope you enjoy. Thank you.
All right, let me just share my screen. All right, can everybody see that? Can somebody see that? Yes, perfect. All right, I'm just going to turn off my video so that we can focus on the presentation. All right, so I'm going to give one of the lectures a little bit later in the year about systemic disease and the manifestations on the heart secondary to that. So I thought that tonight I would talk a little bit about syncope and how systemic disease can affect the heart and vice versa. So I want to take you through a case today that Sadie I saw a few years ago. So she was at the time, 4-year-old female spayed spaniel. And she initially came into the internal medicine service for a chronic GI workup. She had kind of chronic vomiting, diarrhea, and inappetence. And as internal medicine was taking a history, the owner noted, oh, she also, a month ago or so had a seizure in the garden. She was running around chasing a squirrel and she seemed to have a seizure. Medicine got a further history and she had no evidence of exercise intolerance otherwise, no tachypnea, no dyspnea, no cough. And when they examined her during the appointment, they didn't appreciate a heart murmur. Her heart rhythm was regular and her heart rate was 130. So when we're faced with a patient like this, I tend to have a pretty binary mind. I'm a cardiologist, I think about hearts. And so I tend to put these patients in 2 main categories. Is it cardiac or non-cardiac? And with syncope especially, that can be really challenging because there's a lot of overlap in the clinical signs and the history, and sometimes our diagnostics don't immediately indicate one versus the other. So what is syncope to start? It's defined as an abrupt, transient, complete loss of consciousness. And that's often associated with an inability to maintain postural tone, so fainting, and rapid and spontaneous recovery. And the underlying mechanism here, and one of the kind of themes of the night, is that syncope is secondary to global cerebral hypoperfusion. And many times that's related to low blood pressure for a variety of different reasons. We can also have a pre-syncopal episode that's characterized by brief episodic rear limb or generalized weakness, ataxia, or an altered level of consciousness. And one thing that's, I think, really key to remember when we're considering syncope is that syncope is generally a symptom of a disease, not the disease itself. So we kind of have to go on a hunch to figure out why is this, what is the underlying mechanism that is making this dog collapse. And often the very first question that we try to ask is this actually syncope or could this be seizure? And this is something that can be really challenging. We get this on a daily basis, kind of emails to the practice from saying, I don't know whether to send this to neurology or cardiology. And when I was at the Royal Veterinary College, a student did a study where she sent videos of dogs collapsing, either syncope or seizure, to cardiologists and neurologists. And we were pretty good at identifying syncope versus seizure for dogs. We were complete rubbish at identifying it for cats. So cats can be even more challenging. But typically the characteristics that we think of for syncope is they are completely normal before and after the event. The events tend to happen with stress or exertion when they're active. They can be triggered by urination, defecation, vomiting, gagging, or cough, but not always. Often it results in flaccid collapse, but sometimes we do have kind of rigid extension of the limbs. And defecation, salivation are sludge signs, if you remember, are generally unlikely. However, one of the things that I think we all classically learned in vet school is that the sludge signs include urination, and sometimes we do see urination in syncope. So that does not kind of make or break a diagnosis for me. When we contrast that with seizures, typically dogs are abnormal before and after that event. They can often occur when the animal is at rest or it's sleeping, often at night. There's generally no discrete triggers. We have tonic-clonic movements, so rhythmic movements of the limbs or facial twitches. And then we often see defecation, urination, or salivation during the event. So I have a couple of videos here. Hopefully they work. And they're not the most pleasant videos to watch, but classic example, your pre-syncopal episode in this boxer. So you can see her go down. She doesn't completely lose consciousness, but she loses her postural tone, and then she recovers and walks away and is normal. Whereas in this dog, obviously this upcoming dog looks like a very different event. Okay, so this is tonic-clonic movements. This dog is not aware of what's going on. It's got facial twitching. The event happens for a much longer period of time. I know it's a pixelated video, but there is hypersalivation there. And then when the event starts to wind down, the dog still is mentally, neurologically abnormal. So I think first step is to try and figure out, is this an issue for a cardiologist or a neurologist? And if we are confident that it's syncope, then we start to think of all of the different causes of cardiac syncope. And I think one of the first things that our brain jumps to is arrhythmias. So we can have either bradycardias or tachycardias, but we can also have structural heart disease, whether that's congenital or acquired in older dogs. And then we have our, what I want to say, maybe cardio-adjacent diseases. So pulmonary hypertension, truly that's a disease of the lungs, but realistically, we as cardiologists will diagnose it. And then our neurally mediated syncopal episodes. And we're going to talk a lot about that today and what exactly that entails. So with tachycardia, if you have a dog collapse because of tachycardia, it is almost always because of ventricular tachycardia. I think people always assume that even if you have a fast supraventricular tachycardia, dogs can collapse because of it. But when we look at the studies and review the literature, it doesn't actually happen very often. Rarely it can, but most of the time, if you have a dog collapse because of a tachycardia, it's most likely ventricular in origin. And then we have a variety of bradycardias that can cause collapse as well. So kind of classic atrioventricular block, either third degree or high grade second degree, sick sinus syndrome, atrial standstill, whether that's primary cardiac disease or secondary to hyperkalemia, or sinus standstill itself. And then there are a variety of different congenital heart diseases that we can see that cause collapse. And you're going to have several lectures on advanced congenital disease, so you'll be able to discuss this in a little bit more detail. But I think the two most common causes of congenital heart disease that cause syncope are aortic or subaortic stenosis, which we have a picture of here. So in this is an angiogram, and you can see a large TOE probe, and then a, turn on my little laser pointer here. So we can see the TOE probe here. We can see a catheter coming down the brachiocephalic trunk into the ascending aorta and into the left ventricle, with contrast filling the left ventricle. So this is our aorta here and our aortic arch. And hopefully what you can appreciate is there's a really discrete narrowing here that's below the level of the annulus. And that's going to impact cardiac output. That's going to impact cerebral perfusion. And if you have a dog that takes off across the lawn for a squirrel, it might not be able to keep up and we might have a syncope. Pulmonic stenosis, similar. So with severe pulmonic stenosis, dogs often collapse with exertion. We can see that because of tetralogy of Fallot. So that's going to be both a combination of pulmonic stenosis and a VSD. So we can not only have our obstruction to flow leaving the heart, but we can have right to left shunting and cyanosis as well. And along the same lines, we can have all of our right to left shunts. So our cyanotic congenital heart diseases. So a PDA or reverse PDA. Those dogs tend to have a very classic presentation where they collapse only in the hind limbs and do not have collapse or cyanosis in their forelimbs. These dogs almost always end up going to neurology because they maintain consciousness throughout the event. It looks like hind limb weakness in the when they're running. But we can also have right to left shunting VSDs, AVSDs, so atrioventricular septal defects, and atrial septal defects as well. And then we've got our congenital heart diseases as well. Just play that for you. So dilated cardiomyopathy, mitral valve disease. Realistically, these diseases have to be pretty severe in order to cause syncope. So if we have mild disease and a syncopal dog, then I tend to look elsewhere. Hypertrophic cardiomyopathy, cats can collapse. Normally it's because of if they do collapse because of structural heart disease, it's because of severe left ventricular outflow tract obstruction. But most of the time, if I have a cat collapse with structural heart disease and HCM, I'm more concerned about ventricular tachycardia rather than a structural lesion. Pericardial effusion, very classic reason that the dogs collapse, and thankfully this is one that's fairly easy to diagnose. And then cardiac tumors, they kind of do whatever they want. I've had a dog that had a mobile tumor attached to the pulmonic valve that would intermittently flip back and forth between the right ventricle and the pulmonary artery and completely occlude outflow. And that dog was collapsing very frequently. Pulmonary hypertension, you're going to have a whole day on pulmonary hypertension, so I don't want to steal anybody's thunder, but this is a very classic cause of syncope with exertion. And like I said, this is really a disease that is pulmonary in origin. The heart in this situation is typically the innocent bystander, but we are the ones that end up diagnosing it. In humans, gold standard diagnosis would be catheterization, but obviously for many reasons we don't jump to that in dogs. So we're the ones that often see it kind of on the front line, if you will. And it can be because of a variety of different causes. There's a great consensus statement. If you haven't read this already, I would encourage you to seek that out. It's an ACVIM consensus statement, so it's open access. That could be because of pulmonary arterial hypertension, either primary or secondary to volume overload, like a PDA, secondary to left heart disease. Although typically when we see pulmonary hypertension secondary to left heart disease, it's not quite severe enough to make a dog collapse on their own. Respiratory disease, hypoxia, tracheal or bronchial collapse, pulmonary thromboembolism, if you have an IMHA dog or something like that. Parasitic disease, from my neck of the woods, it's typically heartworm disease. This is a radiograph of a dog that I treated for heartworm disease in North Carolina. And I think at first glance, many people would end up giving this dog furosemide for left-sided heart failure. But when you take a closer peek, you can see that we have just absolutely huge pulmonary arteries here that are tortuous in nature, whereas our pulmonary veins are actually quite small and our left atrium is quite small. We've also got a little bit of a effacement here from some right-sided heart failure. But obviously in the UK, we're more concerned about lungworm, but we do see the odd dog here or there that's either traveled or been imported that does have heartworm disease. And then finally, 6 multifactorial. So obviously, these things don't happen in isolation, and you can have many of them occur at the same time. So, Sadie was here, medicine came over and had a chat with me, and I said, absolutely, any dog that's syncopal needs a cardiac workup. So we did an echocardiogram. It was completely normal, systolic function normal, chamber size normal, no evidence of structural heart disease, pulmonary hypertension, anything like that. ECG revealed sinus rhythm the entire time that she was on the table. And we said, well, let's put a Holter monitor on. We'll see if we can catch one of these events. But when I have a dog where my echo is normal, my ECG is normal, and I don't have anything that is making me think cardiac, then I start to think about non-cardiac differentials. And there is a massive list. This doesn't even include everything of different non-cardiac diseases that can cause collapse. So we already talked about epileptic seizure, but we can have other forms of neurologic disease, narcolepsy, cataplexy. We can have neuromuscular disorders. We can have paroxysmal movement disorders, twitching, patients that seem kind of out of it, but actually it's the movement that's causing them to feel a little bit strange. Stroke or transient ischemic attack to the central nervous system. Hypoxemia, whether that's severe lung disease or any one of the thousands of Frenchies that are coming in through the clinics these days. Metabolic diseases, hypoglycemia, maybe this patient has an insulinoma. Maybe they've got severe liver disease and have hepatoencephalopathy. Hypertension, whether it's just primary hypertension or secondary to a pheochromocytoma. And those can be really tricky because they can be intermittently hypertensive. So maybe when they're in the clinic, they actually measure normal. Central or peripheral nervous system disorders, or exercise-induced collapse, which has been seen in Labrador retrievers. So when we get one of these dogs, I often warn the owner that we really do have to cast a really wide net to try and figure out what's going on. Unlike some of our dogs that come in for a murmur evaluation, I'm not going to be able to give them an answer to why their dog is collapsing necessarily the moment that I look at their dog's heart. So for me, obviously, I'm a cardiologist, I'm going to do the heart things. I'm going to do an ECG, but that does not rule out an arrhythmia. So we always do Holter monitors as well, and an echocardiogram to rule out cardiac disease. But I'm also going to submit some systemic blood work, starting with a hematology and a biochemistry to look for anemia, polycythemia, low glucose, lactic acidosis. But we often have to go from there. Maybe this dog is Addisonian, maybe it's got high vagal tone for some other reason. Definitely a blood pressure. Often I move to imaging to look for neoplastic disease in the abdomen, to look for pulmonary disease or something that would cause pulmonary hypertension, and to look for effusions. I had a dog referred to me a few weeks ago for collapse that ended up just having very, very severe pleural effusion secondary to a chylothorax. So that dog its heart was normal, but it had effusion for another reason. And then I often kind of start with a neurologic exam. And the frustrating thing is, as I'm sure you all know, is that most of the time between seizures, these dogs are normal. So a normal neurology workup or a normal neurology exam doesn't rule out neurologic disease. But because the neurology workup tends to be a little bit more invasive and a little bit more expensive, realistically, I often start with some of these screening tests first. So she was with the internal medicine service, and we know the internists are super thorough, which is wonderful. So they did a whole host of tests on her to try and figure out what was going on. So in addition to her cardiac tests, they did a blood pressure, which was normal, and some blood work. And on biochemistry, she had elevation of her BUN, but her creatinine was normal. And on hematology, she had a mild to moderate regenerative anemia, but the rest of her parameters were normal. And then finally, on abdominal ultrasound, they looked at her adrenals, they looked at her liver, they actually sampled her liver and did some aspirates of both the spleen and the liver, and those came back normal. No obvious evidence of pancreatitis or pheochromocytoma, but she did have some changes along her GI tract that were consistent with a chronic enteropathy. So based on kind of this pattern, as well as her chronic GI signs and her medical history, they were suspicious that she did have, chronic gastrointestinal disease, potentially IBD, with potentially some bleeding in her GI tract as well, due to the BUN elevation and the anemia. So then we got her Holter monitor back. And this was, we were lucky in that we caught a collapse episode. And one of the super frustrating things that you probably have experienced yourself is that for some reason, dogs will collapse every single day, then we'll bring them into the clinic, put a 7-day Holter on them, and then they don't collapse for a week. Often they collapse the minute you take the Holter off. I think it's kind of like bringing your car into the shop because it's making a noise, and then, you get there and the noise stops. But thankfully, Sadie actually did have a collapse episode while she's wearing the Holter. So you can see this episode here. I blew it up for you so that you could see a little bit better. And you don't have to worry about the numbers or the letters. That's just the Holter program. But what you can hopefully appreciate is we're in a sinus rhythm. You have to trust me a little bit because I know it's tiny, but we're in a sinus rhythm throughout the top strip. And then our kind of sinus rhythm gets a little bit faster, faster, faster. We have this movement artifact here. And then we have a pause. And then we have some sinus beats come in, some ventricular escape beats come in. Down here we have an escape rhythm, so we don't have any P waves, we have ventricular escapes, and then our sinus rhythm comes back in. Okay, so this is what her heart rhythm was doing during her episode of collapse. And I think what a lot of people would say, and what many cardiologists used to think this was sick sinus syndrome. I think many people look at this and say, well, you've got a long sinus pause. It must be sick sinus. But I'm going to argue that I don't think that this is sick sinus syndrome. And I think that we have in the past potentially overdiagnosed sick sinus syndrome. So why do I say that? Well, sick sinus syndrome is normally a collection of arrhythmogenic abnormalities, and because it's a syndrome, a clinical sign, so collapse. And often we see a combination of sinus bradycardia, many periods of arrest within that sinus rhythm that are interrupted by junctional or ventricular escape complexes. And these escape beats and rhythms are often delayed. Often we'll see variable P wave morphology as we see up here. So up here I've got, this is lead 2, so I should have positive P waves. Whereas here I have negatively deflected P waves, but then they flip back into a positive deflection after this long sinus pause with no activity. I can have supraventricular tachycardias, which often follow or precede a bradycardia. So that's so-called Brady-Tachy syndrome. And very commonly, I have concurrent atrioventricular conduction disturbances as well. And there's a really good paper. It's really heavy and long, but it's a good paper by Sydney Moise, who's kind of the sinus node guru. And she set out some parameters that we can use to try and diagnose sick sinus syndromes in dogs. And often their average heart rate is less than 60 beats per minute. They have a minimum heart rate of less than 30. They have longer than 350 minutes within the period of a day with a heart rate less than 50. They have lots and lots of pauses longer than 2 seconds, or a long pause greater than 5.5 seconds, or more than 3 pauses greater than 4 seconds. So again, this is a syndrome. They don't have to tick every single one of these boxes, but this is the picture that we see on a Holter monitor of a dog with sick sinus syndrome. And that was not what we saw with Sadie. We saw a completely normal Holter apart from this one episode. She did not have any bradycardia. She did not have any other pauses. It was completely normal apart from that one pause when she collapsed. So if this isn't sick sinus syndrome, then what is it? And for me, that is a Holter monitor, and that's a clinical history that's more consistent with neurally mediated syncope. So neurally mediated syncope is a complex interaction between your brain, your heart, and then those have impacts on your heart rhythm and your circulation. And there are a few different kind of subcategories of neurally mediated syncope. A lot of people will just say neurocardiogenic or vasovagal and mean kind of all of these. And it's a little bit nitpicky to try and pull them apart, but hey, this is the advanced cardiology certificate, so we want to be a little bit nitpicky. And so we have kind of 4 different categories that we talk about. Neurocardiogenic, which is the most common that I think we appreciate. Vasovagal, situational, or carotid sinus syncope. So neurocardiogenic is syncope that is secondary to a reflex that is triggered within the heart or the pulmonary arteries. And what happens is we get a sympathetic surge, and then that causes the efferent reflex that resembles an exaggerated baroreceptor response. And ultimately, that leads to a combination of bradycardia and vasodilation. So if we're talking about an exaggerated baroreceptor response, let's kind of go back to what your normal baroreceptors do. And I think the easiest way to think about this is a situation that we've all experienced, which is when you get up too fast. So let's say you're sitting on your couch, you hear that your cat is about to be sick, because this is the thing that gets me out of my chair the fastest, and you jump up to run and try and prevent the mess from spreading. Okay. So when you stand up, because we stand on 2 feet, all of the blood will essentially go down towards your legs. Okay? Gravity pulls that downward, and your blood pressure systemically and near your heart falls. Your baroreceptors, which are receptors that are located in your aortic arch and carotid sinus, sense this drop in blood pressure. What do? Well, they send that signal to the brain so that it can be processed and so that you can address it. And so the brain, in response, creates a decrease in vagal tone and an increase in sympathetic tone. And both of those actions concurrently lead to an increase in heart rate and vasoconstriction. And the opposite can happen too. If your blood pressure goes too high, then that gets sent, and the opposite happens to slow your heart rate and vasodilate. But in this situation, we're vasoconstricting and increasing our heart rate so that we increase our cardiac output and don't faint when we stand up. Now, vasovagal syncope is similar, but instead of the reflex being triggered within the heart, it's triggered in the brain. And that typically happens in response to an emotional shock or fear or pain. So if you've ever, you have a family member that faints at the sight of blood or a vaccination, that's a very classic vasovagal episode. We also have situational, and we do see that in dogs as well. And normally that happens again from a surge in vagal tone. And I tend to see it more in my patients when we've got big swings in adrenergic tone. So maybe their sympathetic system was really high, and then one of these events happens and we get a big swing from sympathetic to parasympathetic. And that can happen with tussive syncope, so coughing, vomiting, defecation, or urination. I once had a client where he would take his dog for a walk. While his dog was defecating, he would pick up a ball, and as soon as the dog was done, he would chuck it across the park, and the dog would just take off. And without failure, the dog would go 3 steps and then collapse. And we said, maybe give him a little time after going to the bathroom to throw the ball, and the situational syncope stopped after that. And then finally, we have carotid sinus syncope. So that arises from mechanical pressure on the carotid sinus. That's very well documented in humans. I don't know that we know that it happens in dogs. My suspicion is that they are less sensitive to it because how many dogs are constantly pulling on their lead and they're not collapsing all the time. But we don't really know is the honest answer. So we said that a lot of this is an exaggeration of the normal reflex. And so when we think about this reflex kind of cycle, we've got our trigger, which is the afferent limb of the reflex. That goes to our brain, and then the efferent reflex responds. And I promise that's all of the neurology that I'm going to talk about in this talk. But in syncope, the trigger can either be neurocardiogenic, heart, pulmonary arteries, or centrally mediated, as in vasovagal. But our response can be a little bit variable. So we can have a cardioinhibitory response, which is primarily bradycardia and reduced cardiac output. Or we can have a vasodepressor response, which is vasodilation. But more often than not, we have a mixture of both of these. And that is really important when we're thinking about treatment for these patients. So neurocardiogenic syncope is what we appreciate most commonly when we're discussing neurally mediated syncope in dogs. As I said, it's adrenergically, so sympathetically stimulated. And clinically, it looks like many other episodes of syncope. So it normally lasts less than 60 seconds. It's often super, super quick. And they can have all of the same clinical signs of collapse. So sometimes their mucous membranes will go pale. Clients often pick up on that. Or they can be cyanotic. Sometimes they look like they're not breathing. Sometimes they're very bradycardic. These are the clients who say, I thought she died and I started CPR and then she came right back to life. The sinus bradycardia can proceed to sinus arrest, but it doesn't necessarily. We can have atrial nodal or ventricular escape beats, but we don't need to. And then sometimes we'll see a reflex sinus tachycardia that can occur after these events. So sometimes it feels like their heart is racing afterwards. And there are 2 really good papers that have discussed these findings over the last couple of years. This is the first one, and they looked at heart rhythm characterization during unexplained loss of consciousness in dogs. And they had Holter monitors in 92 dogs that collapsed. The rhythm at the exact time of collapse, about 72% of the time was ventricular arrest, as in this dog, so a pause, basically. Some dogs collapsed whilst in sinus bradycardia. Some dogs, about 20% of dogs, did not have a significant rhythm variation, and only less than 1% of dogs were tachycardic. When they were tachycardic, it tended to be ventricular tachycardia. I think one dog ended up being in supraventricular tachycardia of 92. But that no rhythm variation is really important because it's that combination, that mixed response of some dogs have bradycardia, some dogs have vasodilation, and some dogs have both. So sometimes we look at a rhythm and we say, well, this doesn't look like it's slow enough to potentially cause syncope, but it's not just the rhythm in these dogs. And reviewing all of these collapse episodes, they suspected that about 50%, just shy of 50% of these cases were actually neurocardiogenic syncope. I think this is something that previously we've massively kind of underdiagnosed in our collapsing dog population. 30% of those dogs had sinus or AV nodal dysfunction, which we are much more comfortable with. There was another paper that looked specifically at boxers, and boxers, if you read any textbook about syncope in dogs, boxers tend to be more prone to vasovagal episodes. So it's kind of the emotionally driven ones. They tend to be a little bit more delicate. I have a boxer mix, so I think I can say that. But similar findings here. So this was an episode of collapse in a dog, and what you can hopefully appreciate is, yes, there is a small sinus pause and there is a ventricular escape rhythm, but these pauses aren't typically long enough to actually make a dog collapse. Normally a collapse episode secondary to a sinus pause, if it's purely arrhythmogenic, that pause has to be about 8 seconds before they'll go down. And so sometimes we'll see the heart slow, but it shouldn't be slow enough that they're collapsing just from the bradycardia alone. And that's why we think that vasodilation, that hypotension concurrently plays such an important role in these dogs. So the physiology behind neurocardiogenic syncope, it can be a little complex, but it all comes down to basically the mechanoreceptors that you have in your ventricular myocardium. And this is the same for humans and dogs. So you have something called a C fiber, which is a mechanoreceptor or a stretch receptor. And that typically is located mostly within your ventricles, especially the left ventricle. We have a few in the left atrium or a few in the pulmonary veins. And in normal situations, that is activated by increased pressure. So if you have a surge of sympathetic tone because you step out in the street, you almost get hit by a car, you get sympathetic stimulation, you get vasoconstriction, you get return of lots of preload to the heart, your contractility increases, and your stretch receptors are activated. And it's kind of a protective mechanism, right? A lot of vagal and sympathetic tone, it's feedback to try and keep you kind of moderate. If you get too stressed, your vagal system starts to be activated. If you get too sleepy, you want your sympathetic tone to maintain all of your hemodynamic parameters while you're sleeping and that sort of thing. So that's what's supposed to happen normally. But what can happen with neurocardiogenic syncope is it's a little bit altered. It's not really working the way that it should, and that happens often because of other things that are going on in the body. Hypovolemia, dehydration, sometimes severe structural heart disease, and if for some reason your ventricle is underfilled, but we still have very high contractility, then these C fibers can still be activated. So we think of this often as kind of an empty ventricle that's contracting super robustly, and that will still activate these C fibers, and we still get that response. So we get the parasympathetic enhancement, so we get bradycardia, and we get withdrawal of sympathetic tone. So we reduce vasoconstriction, which leads to effective vasodilation, and that leads to hypotension. So we've got an underfilled ventricle, and now we're making it slower, and we're decreasing preload because we've got vasodilation peripherally, and then we start to collapse because we've got bradycardia and vasodilation and an empty ventricle, and we've got reduced cardiac output, and then our cerebral perfusion decreases, and then we pass out. Now, In humans, there's you can kind of go down a huge rabbit hole with this. There's lots of super interesting information, and they have done a lot more work in diagnosing this disease and trying to parse out the mechanisms of it. And it can be really, it can be really challenging for people that have neurocardiogenic syncope, because it can really affect your life. So one of the main tests that they would do in humans, again, because we walk on two legs, is something called a tilt test. And so they basically want to see, is your baroreceptor mechanism working in the correct manner? So it's an orthostatic stress test. So what they do, it sounds very unpleasant, probably because this is a common test. Either someone here or someone has probably undergone this, but they basically strap you to a table, and you start off recumbent, so you're laying down, and then they tilt you up fairly quickly to see what happens. And in healthy people, you tilt, and we get that normal baroreceptor reflex that we talked about. So it causes a reduction of venous return because that gravity pulls it down towards your legs. We get our activation of baroreceptors, and then we get increased alpha tone for vasoconstriction, increased beta tone for our contractility and our heart rate, and that maintains our blood pressure up at the top of our body, as it should. But in affected people, because that reflex mechanism is not working as well as it should, or is working in an inappropriate way, that decreased venous return causes those C fibers to start getting activated, because you're contracting with an empty ventricle. And then we get a sudden withdrawal of sympathetic tone, an increase in vagal tone, and then that person faints. So how can systemic disease lead to worsening of these events? Well, hypovolemia is really important. We're talking a lot about empty ventricle. So, you want your preload to be normal. With hypovolemia, your sympathetic tone is already increased. So your balance between your sympathetic and your parasympathetic systems it's a little bit off already. And then we've got hypercontractility of the myocardium. If your cardiac output is decreased, you're going to already have activation. You're going to be trying to increase your heart rate and your contractility to maintain cardiac output. And so we get that secondary stimulation of C fibers. And the same thing can happen to dogs, even though they're walking on 4 legs instead of 2. And then anemia can affect our reflex as well. And obviously, aerobic metabolism is requires delivery of oxygenated blood to all of the tissues. And there are a lot of different factors that go into metabolism and delivery of oxygenated blood. Your hemoglobin concentrations and your O2 carrying capacity, your cardiac output, your oxygen extraction, which is a volatile thing and can change depending on your activity. And so for me, when I was initially learning about this, I thought, well, if you're anemic and you have decreased oxygen delivery to the tissues, then maybe you're more likely to pass out. But it's actually a little bit more complex than that, and a little bit more interesting than that. So there are a few different mechanisms by which anemia can worsen vasovagal syncope or neurocardiogenic syncope. One is that when you have low iron stores in your body, it affects metabolism of your catecholamines, and so it can throw that balance off even more than it already is. Often you have peripheral vasodilation secondary to anemia, and that's something we're going to talk about in one of the other sessions that we discuss in systemic disease. So one of my favorite topics is thyroid, and how the thyroid can affect the heart and vasculature. And if you are vasodilated peripherally, that prevents you from vasoconstricting. and that can affect your baroreceptor response and make you more prone to collapse. And then finally, in people, this hasn't been documented in dogs, but in people, they have evidence of splanchnic pooling, so pooling kind of within your liver, your spleen, and that can make you more resistant to a normal orthostatic response, so a normal kind of recruitment of that blood to help maintain your blood pressure. All right, so how do we treat neurally mediated syncope? Well, the first thing to remember is that normally this is benign, so it is unusual for a patient to die from a neurally mediated syncopal episode, but it is unpleasant, so we definitely want to treat it. The first thing is avoid triggers. You know, in humans, they say make sure that you're eating salty foods and then drinking lots of water to stay hydrated. Treat the underlying systemic disease. So if the dog's dehydrated, treat that. If a dog's anemic, try to fix that. In humans, they've looked at several medications, beta blockers to try and decrease that sympathetic surge, don't seem to be effective. Alpha agonists can be helpful in increasing peripheral vascular resistance and then increasing venous return to maintain your preload, but they do have some side effects, so we don't typically use those in dogs. And pacemakers. So most of the time, the fall in blood pressure actually comes before the bradycardia. And as we discussed earlier, sometimes the bradycardia itself is not significant enough to make you collapse. So oftentimes pacing is ineffective, and most of the time we don't pace these animals. I have been tempted to do it in the past, if you know, as kind of a Hail Mary, if you will, to try and do anything that I can to prevent these episodes. But you have to kind of warn the owner that if this is mostly from the blood pressure, then putting in a pacemaker is not necessarily going to help. Dual chamber pacing might be more effective to help you maintain your cardiac output. But again, if the blood pressure is the problem, then having a faster rhythm is not necessarily going to improve that. So what did we do with Sadie? Well, the internal medics are great, and they treated her chronic enteropathy. So they switched her exclusion diet, put her on gastroprotectants, dealt with her anemia, and her anemia resolved. And she has been 2 years without any syncopal episodes now that her anemia has been fixed. So this is a really classic example of, you know, this was not sick sinus syndrome. This dog did not need a pacemaker, but I think previously, you know, maybe before we knew more about neurally mediated syncope, that would have been the conclusion that we jumped to. So just some take-home points for syncope. I'm sure we'll talk about it more in the course, but history is super, super, super important in these dogs. You have to rule out systemic disease. You have to rule out seizures. Videos are incredibly helpful for reviewing, because I think the owners sometimes don't know what to look for. You do have to broaden your scope and consider imaging and blood work on these patients as well. If it is cardiac, consider the signalment murmur, if there's a rhythm disturbance, and then the things that are truly emergent syncopal episodes, VTAC, AV block, heart failure, I would add pericardial effusion to that list. And for our cardiac diagnostics, it's mostly echocardiography, POCUS, ECG, and then Holter monitors. I mean, we're so dependent on Holter monitors in these cases. So it's a really important tool to have. I'll kind of leave this up here for a second so that you can come back and look at some of these resources if you want. The one shout out I would say is that CVT, so Current Veterinary Therapy, has a really great web chapter on syncope. If you have that, I would definitely check it out.